Hello, and we welcome you to our third Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vasallo, the managing editor for the series here at Elsevier, and for this podcast, we will be discussing 4 articles in the June 2022 issue on cardiothoracic surgery. Here to discuss methods of lung cancer resection, management of coronary artery disease, and cardiac dysrhythmias will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the Cardiothoracic Surgery issue, Dr. Daniel Quadrato, Chief of Cardiothoracic Surgery at Madigan Army Medical Center at Joint Base Lewis McChord, Washington. Welcome to both of you, and over to you, Dr. Martin.
Thanks, John. I appreciate it. And Daniel, it's so good to see you again. And I miss having the office right next to yours and seeing you every day and getting your advice and input. More than you can imagine. I wish I had you with me, but I know you're better off where you are. Thanks again for doing this issue. It's been really well received and super helpful. And we have 4 articles we're going to discuss today. And if it's okay with you, I think we'll start out with the 2 on lung cancer, and then we'll move into the cardiac ones if that meets your approval.
Sounds great.
I thought I'd start off with the one on MIS lung resections, minimally invasive stuff. One, it's certainly topical and exciting, but also you're a phenomenal minimally invasive surgeon and robotic surgeon in addition to your other skills. So a couple of things I thought we'd start with that chapter. And one is, I think, at least for the general surgeons in the audience, the people that don't do thoracic every day, run us through where we are now with the improved imaging, particularly this ground glass opacification and how we factor that in, and sort of where we're changing our staging and planning based on our ability to get more accurate anatomic information from preoperative imaging for tumors.
Yeah, and I think that's a great place to start. I mean, when we look at just the management of lung cancer in general, it is only becoming more multidisciplinary, more technology and image assisted. Lung cancer screening now is more widely available to most people, even though they say the rates of actual screening in most states are less than 10% of all eligible patients. But with that screening comes finding now small nodules, semi-solid, and ground glass nodules. And, these present a particular challenge in terms of how to localize it to the segment. Because what we know, based on the current best evidence, is that for a tumor less than 2 centimeters, a sublobar resection is equivalent to lobectomy in terms of, oncologic success. Even in the lay press, it's written, there was an article today where they said surgeons no longer have to take out 1/5 of your lung when you have lung cancer. So when it comes to doing a segmentectomy, obviously it's a detailed understanding of the anatomy that's required to determine, is this lesion, is this tumor in a segment that I can resect? So I think for all surgeons, just knowing that, people get CT scans for all kinds of reasons, and not just lung cancer screening, but how we address these small and some solid ground glass tumors, it's really referral to a thoracic surgeon. But in terms of the imaging and planning, there is software now that's available that allows us to 3D model the lung so that you can actually look at the individual segmental anatomy. So I think those tools are making it much easier for us to plan these cases to the point where anyone with a tumor less than 2 centimeters, I think really the default should be to plan for a possible segmentectomy.
So let's follow that up a little bit, because that's one of the other questions I had for you. I mean, if you go back historically, and I've been at this a little longer than you have, we used to focus a lot on the tumor and what we were going to take out. And then particularly liver surgery, and now I think lung and maybe pancreas to a degree, although you could argue you can take all the pancreas out, so you don't have to worry about it. But we've gotten a lot more to how much you have to leave behind versus what you're going to take out. So talk to me a little bit about how do you recommend we go about figuring out how much lung preservation we need and how much functional lung material do we have left based on what we plan to resect? How do we sort through that?
Yeah, I think when you're confronted with any lung cancer patient, I mean, obviously there's really three factors. There's, the anatomic factors, that falls into your staging. Where is the tumor itself? There's the physiologic factor of the patient and their comorbidities. The biggest one for us is their lung function. We can calculate based on, knowing that there's 19 segments in the lung, how much lung capacity will this patient have after a resection? And then the last part of it is really, where the cancer, the tumor gets a, is it falling in a fissure line, or is it against something that makes maybe a segmentectomy contraindicated? So I really think you look at all three of those. But, just because a patient has excellent pulmonary function doesn't necessarily mean we need to take the entire lobe for tumors less than 2 centimeters. Obviously, patients with poor lung function, even for tumors larger than 2 centimeters, a segmentectomy is probably still a better option than definitive chemoradiotherapy. So I think, all those three factors really fall into play when you're determining, who should get a segmentectomy. But I think the goal, if possible, and oncologically sound, should be to preserve as much lung as possible.
And how do you determine, in terms of lung preservation, what's your go-to test? We did all kinds of things. We did split image studies with radionuclides. We've done anatomic guesses. We've done 3D modeling. Where do you think we are today in terms of assessing the non-involved piece of lung and its functionality and volume?
Yeah, I mean, I think obviously the imaging can be very helpful in people with severe emphysema. Most emphysema tends to be at the apices. But in terms of hard numbers that we can make decisions off, it's really the pulmonary function test. The American College of Chest Physicians put out very good guidelines to compress and simplify the evaluation. Whereas before, we would get VQ scans, we would get exercise tests. But now, if you have a patient that has a post-op resection predicted FEV1 and DLCO greater than 60%, you can proceed right to resection. If either of those is going to fall between that 30 to 60%, the next test is not anything fancy. It's can they walk up uninterrupted, stairs? And it's for the folks that don't meet those criteria, that's when you're looking at a more exotic test, whether it be an exercise test to calculate their VO2 max or radionuclide testing if you suspect that they may have some reason why lung is not perfused or ventilated that's behind.
Well, it's good to know. I mean, it's sort of like when we started doing liver transplant, we just got down to blood grouping. We made it a lot simpler. And it's nice to know that clinical assessment still has a place in our world.
It does.
So let's get into something that you're particularly capable of guiding us. So let's talk a little bit about VATS and robotic assisted thoracic surgery, and how do we choose? How do we pick between the two? Does it matter? I think I know some of your answers, but I want to hear from you.
Well, I'm a little bit biased, but I will say that, a well-trained VATS lobectomy surgeon and a well-trained robotic lobectomy, thoracic surgeon, there's going to be very little difference between the, in terms of length of stay, recovery, blood transfusion. So that's a really hard thing to tease out and to show. What really, I guess the areas where I would maybe argue that a robotic resection is a little bit better than a VATS resection is in a lymph node harvest. I think you can definitely get more lymph nodes. I think, anecdotally, and there is some evidence that you actually get more lymph nodes when you do it robotically as opposed to VATS. The flip side is VATS is much, is cost less. You can get a set of VATS instruments, and you can use that set over and over again on every case. Whereas the robot comes very heavy with consumables, not just the staplers, but all the other, cannulas and consumable instruments.
Which one's easier to teach?
I think the robot is easier to teach. And I think the reason why, if you have a dual console, you can very easily and seamlessly pass the case between the resident and the staff. Whereas with VATS, it really depends on what side of the patient you're standing, because there is some work that needs to be done from the back. There is some work that needs to be done from the front, which was the bulk of the resection. So, it's hard to mirror image your mind to teach that. Whereas with the robot, it's as seamless as, hey, you can start off by using these two hands. I'll run the third hand. And then eventually get them to doing the entire operation themselves. Mm-hmm. The other nice thing with the robot is you have a stop. If you hit the camera pedal, every movement stops. So you almost have the brakes you can put on if someone's kind of delving a little boldly into areas they shouldn't. So I do think the robot is, and especially with a dual console system, is much easier to teach than it is VATS.
I think you're right. And having helped some people out with single console robotic stuff, it is really hard to help somebody without the other console.
Oh yeah.
Yeah. But I think you're right. For teaching mechanisms, I think the dual console, and especially the more advanced robots, are certainly the way to go. The stop pedal is the greatest thing ever.
And also, our residents are coming out of their general surgery training better on the robot than someone like me who learned it 5 years after fellowship. So
they are. Where we may be struggling is the other side, which we're about to get into. Is
we will.
On the open side of the coin. So speaking of which, let's move a little bit into the extending resections, which is sort of the other side of the seesaw. Great chapter in there. And I think as we started out with the minimally invasive part, let's think a little bit about the anatomy, because the way it looks like it's breaking out to me, you tell me if I've got this wrong, is we've really got low-grade T tumors, 1 and 2, that have bad nodal involvement. We've got T3, T4 tumors without necessarily nodal involvement. And then we've got tumors that are involving other structures, some nastier and some less nasty. Those are the big candidates as far as I see it for the extended resections. Does that sound like a reasonable breakdown to you?
I think absolutely. Yeah, absolutely.
So walk us a little bit about, let's start out with smaller tumors, but bad mediastinal nodal involvement. What's your process there?
So I think, and it was discussed in one of the other chapters, I think the trend that we're going to see, very similar to rectal cancer and other cancers, is that we are going to start giving neoadjuvant chemotherapy, immunotherapy, or a combination of the two for much earlier stage disease. Because we are, it's biologically different having, nodal spread than having just an isolated tumor that happens to be growing into a rib. So that patient needs systemic treatment. And I think there's a good argument that with immunotherapy in particular, your immune system is never as strong as it is before your operation. So I think that we're going to see more and more of that. But I really enjoyed this chapter because it's a cautionary tale that not all tumors can be taken out with small poke hole incisions. And for folks who are in charge of teaching, that's a challenge. How do I in a 2 to 3 year fellowship take someone, a trained general surgeon, and teach them how to do everything from robotic segmentectomy to on bypass resection of the aorta, and reconstruction of the heart. So I mean that's a challenge.
You don't say. Yeah, that's so. No, I'm with you, and I think that's the we've gone. If you go back into the 80s and 90s when I trained, where the advanced skill set was to learn how to put in a trocar for a laparoscope. Nobody'd ever done it. That's where we were, to now where we have a point where almost everything is done or can be done videoscopically. Obviously there's a handful of exceptions, but but the comfort level of people coming out of training, I'd say in their first decade right now, they have always trained in the videoscopic era.
Yes.
And with possibly the exception of people that do military work like you and I used to, where you go to a place where it's all open for various reasons. We're really seeing a diminishing group of people that are comfortable with large incision or medium-sized incision operations. Not because they can't make an incision, but because they're just totally unused to the approach and the visualization.
And yeah, again, I think it's the generation of surgeons that put their hand down to feel, as opposed to, and even my generation where I put my eyes down to see. And I know we've talked about this before, but look at how many papers are written on subtotal cholecystectomy. And unfortunately for cancer, there is no, you have to get it all out, or eventually you're going to have, if you don't have that skill set, send it to someone who knows. Because not everything can be taken care of through a minimally invasive approach.
Yeah, ironically, with the gallbladder, you frequently really should get it all out too. We can talk to the exceptions to those rules, but it's becoming an exception in this case that's built not because it's the better operation, because somebody's just not comfortable with the options to go down the road. And I think in your case, in lung cancer, as with, pancreatic and biliary tumors, sort of my side of the world, you got to get an R0 resection. If you're not, that's it. I mean, you got to do what you got to do, or don't do it, go a different route. But there's no such of a thing as a half of an R0 resection.
Yeah. And the tumor always gets a say. I mean, you can go in there, plan A, I'm going to go in and I'm going to do, an apical segmentectomy. And oh my gosh, this is invading the azygos vein, the SVC. That happens. And, you have to have those skills to be able to jump from one to the other.
Yeah. So let's talk a little bit about that. I mean, for the other two parts of this chapter I wanted to get into was one, these extended resection, and the other is sort of the sleeve resections and the bronchoplastic stuff. And so do you have a preference where we migrate in this conversation to?
I think starting with the bronchoplastic, it's kind of a natural segue. And again, the whole premise there is that if you can spare the patient a pneumonectomy, if you can do anything short of a pneumonectomy, you should consider that. The classic one is, the 20-year-old with new onset asthma that has a carcinoid tumor at the orifice of their right upper lobe. Yes, a pneumonectomy will take care of that. It definitively take care of that. But a sleeve resection where you cut the main stem bronchus, you cut the bronchus intermedius, remove the tumor, and sew the two together. It's hard to argue that that's not a better operation for that patient. More so for people who are pulmonary cripples, that you can't do a pneumonectomy, but yet you can still provide them with all of the benefits of a surgical resection for their lung cancer.
No, that's great. So tell me a little bit about, because this is something I have zero experience with other than watching you, but tell me a little bit about the tricks and the considerations that you go through when you're setting up to do a potential sleeve resection and bronchoplastic reconstruction. What are the specific things you feel like you have to have your ducks in a row up front?
So obviously you have to know the preoperative imaging. Obviously the patient history, physiologic, everything needs to be checked first, but you really have to have a good understanding of the anatomy of where you're going to be working. Probably the most common sleeve is the upper lobe sleeve that I talked about. Knowing where the pulmonary artery is in relationship to the airway as you're dividing it. Knowing what maneuvers you can do to release tension, because like all anastomoses, tension is the enemy of this procedure. And an airway anastomosis that doesn't fall apart, that's not something you can put a drain in. That's something that needs to go back in. And oftentimes you may not be able to redo that anastomosis. So, the techniques to get tension off are, again, a good lymphadenectomy, clearing your lymph node space, your lymph node basin, really setting your field for your suturing. There are times where you'll have to do pericardial release maneuvers. So basically making a U underneath the inferior pulmonary vein to release the pericardium. And those are kind of the basic tricks there. But the suturing, it is the same principles as any other anastomosis. You need a good, in this case, airtight anastomosis. And then the final step of that is you should, when possible, buttress that anastomosis with some vascularized tissue, whether it's the pericardium, a flap of pleura, the azygos, or an intercostal muscle. So, those, you have to really have, it's a lot more planning. I mean, the sewing ends up being a circle to a circle, but it's all those things before, after, and, during that are really going to make or break that procedure.
Now, I think it may go without saying, but probably for anybody listening to us who doesn't do this every day, the concept of airway management pre, intra-op, and post-op. This is an anastomosis that if you're going to have a problem with it, you need to know what to do. So what do you recommend people, from our anesthesia colleagues to the people who are in the ICU with the patient, or perhaps give us your rundown on airway protection before and during and after this procedure?
Yeah, so I think, beforehand, a good bronchoscopy, because if you see, and you should do bronchoscopy on anyone you operate in their lungs, but if you see an aberrant anatomy that you didn't pick up on your CT scan, that may totally change your procedure. So the last thing you want to do is get to the point where you're about to cut airway and realize, wow, this bronchus is coming off a different location. In terms of the intraoperative management of the airway, a double lumen tube is pretty much required for this type of procedure, because in that period of, and you must check it before you start dividing the airway, because once you've divided your airway, they can't bring the lung up anymore. So, you will not be able to ventilate. So in my practice, I will do a bronchoscopy myself before I commit to cutting the airway. So I have anesthesia check it, I check it, because if you're looking from the inside, you really can't troubleshoot that anymore. Post-operatively, obviously extubation in the OR is extremely important. You want that patient off positive pressure ventilation as soon as possible, ideally in the operating room. But if someone needs CPAP because they are OSA at home, that's not a downside. I mean, just like with esophageal anastomosis, the data there is pretty clear. You can be on CPAP, BiPAP, whatever you need. And it's just really managing, looking for air leaks. And the difference, we all get air leaks from this when you staple lung. An air leak from an airway is not subtle, but that's something you shouldn't leave the OR with.
And what sort of instructions do you give the crew who's hanging out at night if this person suddenly turns sideways?
That is most of the time it starts with, they need to be intubated, their airway needs to be assessed, and almost, the default is going to be to do all that in the operating room if you can actually ventilate the patient. But if not, it's really, asking the anesthesiologist who's there to emergently intubate and main stem over a bronchoscope, because most of those major airway dehiscences, that's not something you're going to salvage other than a trip back to the operating room.
Sounds good. So let's talk a little bit about sort of the chest wall and things that are growing into adjacent structure tumors.
I think obviously, a good thorough staging evaluation. These folks should always be considered for neoadjuvant therapy. Whether it be chemoradiotherapy, immunotherapy, immunochemoradiotherapy. I mean, there's lots of paths that we can base these on now based on biomarkers. But it's all planning. If you're going to resect chest wall, you really need to know exactly what ribs are involved. I would, basing it usually on their pre-treatment scans too, because it'd be hard pressed to leave behind ribs that the tumor was invading before chemotherapy that is now shrunk down. The classic teaching is to remove a rib above and a rib below the involved area. And then it's a question of reconstruction. There's certain places you must reconstruct. So if it's high and posterior, let's say fourth, fifth interspace behind the scapula, the scapula can sublux underneath the ribs if you don't reconstruct it. If it's in front of the heart, you should reconstruct that as well. There are several different ways, whether it's Gore-Tex, a methyl methacrylate sandwich. There are biological plates now. There's lots of options to do that, but those are things that have to be thought of before you get to the OR. And you can really base a lot of that on your preoperative imaging.
Any room for 3D printing?
I think so. Yeah, and at Madigan, we had a few years ago a very young 4-year-old with a very aggressive sarcoma. And we just tried it just to see what it would look like. And I think, we obviously didn't use it clinically because it really wasn't to scale that we needed, but you definitely could see it. I mean, it would be very nice that you could actually custom order plates based on 3D printing. Probably in the future, you'll be able to custom, design your own ribs to replace ribs. Yeah. That technology is close. But I think for the preoperative assessment, I think it would be nice to show a patient, this is your skeleton, and this is what we're going to do in the OR. And then I'll have that in the OR for my own thought process as I'm going in about my resection. So I think that 3D printing is going to be, and even going back to segmentectomies, I think 3D printing is going to have a huge role in what we do.
No, I think you're right. I think that's an exciting opportunity. And I know you've got some great young people there that have an interest in that part of the project. Why don't we switch gears a little bit and get over to the cardiac side, the heart of the matter?
Yes, the heart of the matter.
And, so, we've got 2 parts to cover left. I think if it's okay with you, let's start with coronary artery disease, which my former chairman would have beat me for saying. He would have said it's atherosclerotic coronary artery disease. You just can't call it coronary artery disease like it's inflammation of the head and neck. You got to be specific. But most of it, we're dealing with atherosclerotic disease, although not all, but a little bit. I think that a lot of people struggle distinguishing between the acute coronary syndromes and the stable ischemic heart disease and how those are different for both cardiac and non-cardiac surgery to follow. So give us your sort of take on how you feel about those entities and their similarities and differences.
Yeah, again, it's the number 1 killer in our country. So I think starting off with that, this is pervasive. And I do agree, atherosclerosis is a systemic disease. They cancer the blood vessels. But I do think that, what we have learned and what you can see through, really years of really good research is that no matter what pathway these patients go, a patient with ischemic heart disease, medical management is the cornerstone of their treatment. So there is nothing that we can do as either interventional surgeons or interventional cardiologists that can match what good medical management can do for most people. And that's your aspirins, your statins, your ACE inhibitors. They are the cornerstone and bedrock of coronary care. I think that, again, so just, with your chronic ischemic heart disease, not everybody needs a stent. Everybody needs good medical management. Not everybody needs a CABG, but everyone needs good medical management. In terms of the acute coronary syndromes, again, that's something that we do see in the post-op. We're not blessed with the opportunity of operating on young, healthy people all the time. And being able to understand and recognize at least the initial steps, which of someone having an ischemic cardiac event. A lot of the patients that you and I take care of are diabetics. They may present with nausea post-op. And that in the back of our mind, we should be thinking, this patient has the risk factors, we H&P, there are all the risk factors there for coronary events. We are sometimes stopping part of their medical therapy to do the bigger operations we have to do. So we really have to be aware of, the presentation and at least the first steps in management before we call in, for our colleagues to come from the cardiology side.
Oh, absolutely. So let's, responding to somebody that's having a problem is one thing. And we tend to focus a lot, like ACLS and all that stuff is great at responding to something that's going bad. But it's always better to head it off at the pass. So when you're thinking about your pre-op eval for cardiac risk factors, for either CT surgery, which I think falls into some slightly more modified guidelines, but for non-cardiac surgery as well, tell us, where do you think we're at with that? I mean, we talked a little about clinical assessment for lung resection. So where do you think we are in the heart world?
I mean, I think let's start with for non-cardiac surgery. So for non-cardiothoracic surgery, I think that, you get a lot of that from, part of our job, part of the, the art of surgery is that preoperative assessment, frailty. I mean, we throw that out there. There are several different ways to do it, but a lot of times it's just something, it when you see it, but the ways you quantify that are you talk to patients, what is your exercise capacity? How far can they walk? Do you have chest pain when you walk? Really kind of the basics of, this is in the get to know you phase with your patient. Also then looking at their family history. I mean, strong family history is a high risk predictor. Patients who already have known coronary artery disease, it's really trying to get that initial gestalt, of do I need to get more of an evaluation? And I think we do correctly err on asking our medical colleagues to help us in that assessment sometimes. We are very focused on, the pancreatic head mass or, the fact that someone needs, another procedure. So I think that really just you have to have a low index of suspicion, but it's really part of the very basic conversation we have when we're trying to gauge the patient's suitability for surgery. For cardiac surgery, again, most patients come to us for cardiac surgery, everything's done. I mean, they have seen their primary care doc, they've seen their cardiologist, they've got a good, their heart has been looked at by echocardiogram, they've had, angiography, some assessment of myocardial function. So, that tends to come in more prepackaged. I think the bigger one for all surgeons to know is, how do you just making sure that you ask those questions, that you don't skip over that step, because a perfect operation can go completely sideways if there's a coronary event during or after.
Always bad form to successfully remove the tumor and kill the patient from an MI.
Yeah.
That's never usually frowned upon by all. But let's talk, we're going through the workup and things have certainly changed. We got all these, and we find something. We've got evidence of either fixed lesions or something else. And so, we've obviously got the pharmacologic interventions. We've got performance drugs for hearts that are misbehaving in some way, but not necessarily non-perfused. But let's talk a little bit about the advances in reperfusion, which I think the chapter in your book really does a great job of. And I commend it to anybody. We don't need to relive the whole thing, but particularly we've got off-pump options now. We've got robotic options now. We certainly have percutaneous options now. But there's a lot more fluidity amongst the team members, I think. But what are your thoughts on that?
Yeah, I think that, one thing that's very well written about is this heart team approach to coronary artery disease, because as you said, there are so many options. Obviously, medical therapy is the foundation that they're built on. It really kind of depends, because the folks that we're seeing are folks that need an operation. So I think we really need to be familiar with that. I mean, if we have someone that has, an LAD lesion, but has a cancer, you really have to have that conversation with the cardiologist, because that may change what type of therapy, whether it's a bare metal stent versus a drug-eluting stent, which definitely the dual antiplatelet therapies are different. There are going to be there are some disease patterns that may need bypass or may need something more advanced, and I think for the surgeon who has a patient with coronary disease that needs additional procedures, you need to be a part of that discussion. You need to be at the table. I do think that the heart team approach to coronary artery disease is very important, because there are multiple ways to deal with it. One very interesting controversy just over the last year were the latest set of guidelines for the management of coronary artery disease, where the Society of Thoracic Surgeons didn't sign off on it. I mean, that some of the recommendations from that group were very percutaneous focused. There was very little input from cardiac surgeons, and without trying to be too controversial, it was based on data that probably wasn't meant to generalize as far as it was. But I do think that it's important for all surgeons to be a part of that decision-making process, because if you need to take someone's colon out for cancer, and they have a lesion and get a drug-eluting stent, now you're either waiting 6 months, 3 months, and they're at much higher risk for an in-stent thrombosis, because the drug-eluting stents are amazing revolutions in medicine. But stopping that dual antiplatelet therapy can be fatal. When a stent goes down, it's a transmural MI. It's not a small event.
And we general surgeons, I mean, everybody deals with their problems to eliminate the problem they're responsible for, which is one of the fractionations of medical care downsides. It's like the neurologist is super happy the patient didn't have a stroke, and then the general surgeon deals with the person who's bleeding to death because they eroded some ulcer into some visible vessel. So they, and I'm not saying one's right or wrong, but the compartmentalization of our discipline has certainly led people to selectively focus on data that supports the stuff that they do or like. And that's human nature. I'm not throwing stones. I mean, everybody does it. But you do have to look at the whole picture. And if somebody's got a bad tumor that needs to come out, and we're going to do something to protect their heart that says you really can't operate on this person for 6 months or a year, years may be a little long, but 6 months anyway, 6 months can be a long time for the wrong tumor.
Absolutely.
Papillary cancer of the thyroid, yeah, you can probably sit tight. Periampullary adenocarcinoma, that without some other thing, 6 months may be the difference between it's coming out or it ain't coming out.
Yeah.
No, I'm with you. And I think one day we'll all get back to having not just heart teams or breast teams or GI teams, but we'll actually go back to having patient care teams where we'll look
the lines are getting blurred, right? There's very difference between me and a pulmonologist, or there's less difference between me and a pulmonologist. There's less difference between a cardiac surgeon and a cardiologist. There's less difference between yourself and a GI physician. We just approach things. We have more tools, but we're using the same tools as well. So,
yeah, you probably, as a cardiac surgeon, you probably have a lot more in common on a day-to-day basis with cardiology than you do with an orthopedic surgeon.
Absolutely.
I mean, and it's not wrong. It's how the game's evolved.
Yeah.
So let's talk about the other than non-perfusion. Let's talk a little bit about the other things that really can be problematic in terms of. Let's talk about dysrhythmias. I mean, of course, there's always the only arrhythmia, which is asystole, which is bad, but that's generally not one we have to talk about much. You just take measures to deal with it if you can. But AFib, by far and away, most common outpatient arrhythmia, and probably, you correct me if I'm wrong, probably the most common induced arrhythmia from other interventions.
Yeah. And, Dr. Hoff, it was a wonderful chapter I had the good fortune to train under him, where they were, really pioneering some of these hybrid procedures for AFib. But, just the burden of healthcare costs, the burden of morbidity in the United States from atrial fibrillation is tremendous. And the effects we see are the folks that are on anticoagulation to prevent the risk of stroke associated with atrial fibrillation. So, I think that the treatment of AFib in particular, that is going to be a very rapidly growing field, for the near future. We now have devices that can close the left atrial appendage. And that is where 90% of clot that causes stroke comes from.
So let's talk about that for a minute. So bring us to, I know some people have probably heard the words. They've heard of Watchman, they've heard of Clips. There's other proprietary names. There's also, operative ligations, but take us a little bit through how you think about that, how you would make choices for one versus the next, or your thoughts on it.
Well, really, I think, at a baseline, any patient with atrial fibrillation who is undergoing cardiac surgery for any reason, that should be considered for an atrial fibrillation procedure. Whether it's just radiofrequency ablation of the pulmonary veins, which is where most of these arrhythmias originate in, and ligation of the left atrial appendage, and that should be considered. In cases where we're opening the heart, let's say to do a mitral valve, typically in a patient with atrial fibrillation, they're going to have a maze procedure, which is the ablation lines internally in the heart to help disrupt these pathways that atrial fibrillation come by. And a standard part of that operation is to operatively close the left atrial appendage. Again, the source of most clots.
Yep.
For folks that aren't having open heart surgery, again, I think that we are being more aggressive with treating atrial. Not everyone can be on Coumadin for the rest of their life, and as procedures become more able to be performed in a less invasive way, whether it be a purely catheter ablation, or versus some kind of combined minimally invasive surgical and catheter ablation, I think those procedures are being considered because, again, it is a significant health burden on our population. We talked about the atrial, occlusion of the atrial appendage. Again, surgically is an excellent way to do it. If you're inside the heart, you're looking at it. When you're outside the heart, again, that's probably some of the reticence to do it because now you're potentially putting another suture line that has a potential of bleeding, but operatively dividing it. The internal devices are very promising, especially for someone who's intolerant of anticoagulation for like repetitive GI bleeds. I think those devices, the next generations of those devices are really going to, probably have a higher success rate. One of the downsides to the current percutaneous ways to close the left atrial appendage are, periprocedural-ish complications, or, it's not completely occluded and you get recanalization or some type of reflow into the left atrial appendage. So I think that appendage is going to be a target of multiple different new techniques and advancements in current techniques to occlude.
Yeah. But I think as I remember reading, because we looked at this a little bit ago, but we're looking at numbers well north of 80% for non-leak rate into the left atrial appendage. Is that, am I correct on that?
Yeah, correct.
Those are pretty good numbers. And you think, now that people are on DOACs or NOACs predominantly, we really don't know how anticoagulated most of those people are. We have a general idea, and we can look at giant studies and say maybe a little bit less bleeding complication than warfarin or some drug where you have to measure it and modify it. And, all the downsides of doing lab work and managing this stuff. But, not just the bleeding complications per se, but the world is a contact sport.
It is.
And 80-year-olds and 90-year-olds, I forget which of the politicians it was, I think one of the congressmen or senators from Michigan before he died, but he said that when you're 90, the entire world is a balance beam. And there's something to be said about that. You're walking around and you're fully anticoagulated, and if every step you got is a chance to fall from ground height and sustain a bad injury, not being able to stop bleeding is not an insignificant problem. Even so, there's big data, and I'm all in favor of data, but you start parsing it down into smaller populations, it may not translate equally well. So I think particularly the elderly don't tolerate clotting well, and they don't tolerate bleeding well. Yeah. So they live in a narrower range of possibilities. And for this group of people in particular, dealing with these issues potentially when they're younger, may have a
Yeah.
huge impact on quality of life 10, 15. I don't think we have a good way to study that yet.
No, I think there's good data with, on warfarin as to your yearly rate risk of bleeding, of major bleeding. I don't think we have that with some of the newer, NOACs, but it's there. And, how many times, if you're covering trauma, are you admitting someone with a ground level fall who's on, dual antiplatelet therapy, novel, oral anticoagulation? And that's one of the main reasons why they're on it. So it is not, I think ground level falls, it's a trauma issue as well. So
it may be purely subjective, but it seems to me like everybody that comes in who's traumatized, either from a fall or a car accident or what have you, who's over 70 that I've seen in the past couple of years, is also on an anticoagulant.
Yeah.
It's almost the exception when they're not.
Because those people don't get driven to the hospital. I think that's part of it.
That's true.
A minor trauma can cause, major intracerebral bleeding or bleeding anywhere. You can bleed to death in your thigh from a fall. So yeah, the elderly on anticoagulant is not a small problem.
So let's talk a little bit about the actual ablative procedures. How many people so clearly for somebody who's undergoing a cardiac procedure, if you're going to be in their mediastinum anyway, for whatever reason, certainly if you're going to be intraatrial, that seems pretty much straightforward that there's a way to approach that during the time of the operation, just make it happen. But it seems like in the outside world, and some of this is anecdotal, I think, that there's a bunch of people out there on AFib who are waiting and waiting on these long lists to get to see electrophysiologists. Do you think that's because we're offering the procedure too much, or should we be trying to get our cardiology colleagues to expand their EPS capability to meet demand? Is this a blip? What do you think?
I think it's a combo of all of it, because look at the population that's there with AFib. Millions and millions of people. So, I think that, yes, do we have enough EP doctors to do all this? No. Probably if everyone wanted procedures, we wouldn't have enough CT surgeons to do it. But I think this is where technology is going to come in, because if you can have a less invasive way, because I can go in VATS and ligate someone's left atrial appendage, but there's really not there are some clips commercially available, but there's not a really easy way to do that. But as I think the technology evolves and it becomes less invasive, we may someday have a very good and efficient way to do this through a subxiphoid, minimally invasive approach and ablate things through the pericardium. And there are techniques available that can do that. But I think that the technology needs to get to a position where we can do that more efficiently. And then you can start offering, and safely and with equivalent results, then you can start potentially offering it to more people. But I agree, there's probably not enough electrophysiologists in the United States to take care of, the massive population of people in AFib. And then I think you may start seeing people that are younger with AFib, who are actually, they're probably more likely to get an ablation because they're young, they're healthy. They're going to see their cardiologist. This may be a more common procedure. You have AFib, you start your medicines, you don't convert on your own. We schedule it for a small, minimally invasive procedure, whether it's surgery, EP, some combination of the two, and you go home the next day, because that's going to be where I think we really need to see technology advance more to make these less invasive, so we can make them more available.
Now, if you're planning on doing an intraoperative ablation on somebody for whatever reason, what, if any, mapping do you need done beforehand? Are you good just on anatomic grounds, or do you need EPS mapping?
I think the beauty of the Maze procedure, again, that's a procedure that has, what is it, the Cox Maze 4? So that tells you that that's a process. It's like the Belsey Mark 4. There were 3 other before it. So I think that as our understanding, and this is working with our cardiologists, is our understanding and ability to map out the area that's causing, or that maybe the focus of the arrhythmia, or the pathways that need to be ablated. If you're opening the mitral valve, very easy. That not very easy, but it's a standard way that you can approach it. I think the bigger challenge is for folks that are getting, let's say, an aortic valve or just a coronary or isolated coronary surgery where you're not planning to open it. And then, probably pulmonary vein isolation and ligating the appendage, that's better than nothing. Is it as good as, maybe having the EP touch that up later? That might even be better. So, I think that it's going to be some kind of hybrid, truly heart team approach that's tailored for every patient, because someone getting a mitral is very different than someone having isolated coronary surgery.
Well, I think that point you made needs to be underscored, in that we have far too few people in yours and mine's line of work who want to try to tailor the solution to the patient's needs rather than bend the patient to what they're comfortable doing. And I get it. But having good teams and people like you that, are really expert in their field that you can discuss this within the support, we really need that on all sorts of levels. And, you and I have worked in some very sophisticated environments and some very austere environments. And there are ways to share information in both. Certainly with the federal government's pocketbook, it's a little easier to have communication to places that are really remote than maybe the private sector is up to on any given day. But I think the concepts are the same. But we really need, I think the one of the great values of the issue that you and your colleagues wrote to me is it gives everybody a really excellent base to know what questions to ask and to know that they need to talk to people about things. And if they do that before things begin, they're far less likely to get into a jam as the process goes along.
Yeah.
So we thank you for that.
Yeah. One of the other things, if I can get a minute, is one
sure.
of the things that I really like that Dr. Hoff talked about that I think applies to all surgical disciplines is pacemakers. How many times when you have a patient with a pacemaker that we just say, yeah, throw a magnet on it, it's going to be fine. But I really liked, and he very specifically in a table, he showed you what it means when someone is DDD paced or VVV paced, and how to approach that, and what the role of electrosurgical, where you put your grounding pad, because those are things that affects an orthopedic surgeon as much as it affects a cardiac surgeon or any surgeon using electrical energy. So I really think that understanding, we should all have that base understanding, just like we should understand dual antiplatelet therapy.
Well, I think you're right, and I'm glad you brought it up. I'm sorry I didn't bring it up before, but I can remember when I was involved as a junior resident with the first implantable cardio defibrillator in Maine. And the news teams were there. We had this giant box with switches all over it. We were sewing these pads onto the heart that looked like fly swatters. It was unrecognizable compared to today's gear. But the principles are the same. It's like if you go back to the old computers that were working on tubes, and now you pick up your iPhone and you get more computing power than NASA had in the whole Apollo program. It's unrecognizable under the hood, but the basic principles are absolutely identical. And that chapter or that section within it with the tables on dual ventricular pacing, what the sensing options are, what the delivery options are, and how you address it, some of the programming features, that cannot be taken for granted.
Not at all. Just basic electrosurgery. I challenged one of my residents the other day when we had a patient with a pacemaker. I'm like, okay, where should we put the grounding pad? And then I asked, why do we put the grounding pad there? Where does the energy come from? Where does it actually go? And where does it go back to? That's a really basic thing that I think a lot of us take for granted. In our trainees may not know. How does electrosurgery work? And, why should I put this pad away so that I can maybe draw current away from the box that's keeping that person alive when we're done?
No, you're right. It's tough. And even just the concepts of monopolar versus bipolar, what does it mean to add blend or spray? And I get it. If you really want to start getting into Fourier and Lorentz transformations and draw out the circuits, that's electrical engineering that most physicians didn't learn. Bovie happened to be a Mainer from my great home state. So in Maine, if you trained there, you were forever beaten up on what the settings did in the Bovie machine. When you turn the knobs, what happened? It's gone away because everybody who knew forgot. But you're right, there's a handful of people out there that remember, but the practical aspects of it are there. And our anesthesia colleagues, the whole team needs to get it. Yeah. OR nurses, but we as surgeons ought to be responsible. We shouldn't be just delegating that responsibility to somebody else, to know that where the pads are, what kind of energy devices we're going to use. Although I do think there's a resurgence in interest in energy enclosure devices and even clips. There seems to be a lot more bubbling around in the community about that than there was, say, maybe 10 or 15 years ago. I think robotics in part has driven that.
Yeah, the bipolar set, yeah.
Yeah, well, and even just people are trying, they were trying to, like, again, bend the patient to fix their closure device. Now they're trying to come up with clips and devices that are a little more specific for what they're doing, which is probably a good thing. It could be overdone, but I think it's probably a good thing. But no, you're right. That chapter on pacemakers, super critical. And implantable defibrillators, I mean, everything's going to get implantable before long.
Yes.
And we certainly, our orthopedic friends, they're putting enough metal and hyperconductive elements into people that it changes the program too. I mean, people always worry about where the total hip is and, where the knee joint is, but they don't necessarily worry about where the pacemaker is.
Yeah.
And they should. Well, I'm glad you're asking the residents. They need you for that, as do we all. Anything else you want to bring? I mean, there are certainly batches of other dysrhythmias to consider. I think we as surgeons, and you correct me if I'm wrong, I think we've gotten a better handle on the volumetric issues we used to deal with and the stretch-related issues, not maybe completely, but at least somewhat. But any other things you want to think about in terms of prevention of dysrhythmias around the time of operations?
No, but I think that, the CHAD score is very helpful, when you're considering someone for surgery that you may need to adjust their anticoagulation plan. Because, if you have a low-risk patient, it's perfectly fine to just stop their anticoagulation, especially for a high-risk case, and leave it stopped until you're out of that period of time. So, those scores, I think, are really there to help us. You don't have to do all of this, philosophical decision-making. You have some hard objective evidence that say this is safe. This patient is extremely high risk. I need to start them on anticoagulation as soon as possible, or in some cases, may not discontinue it at all. So, depending on the procedure. So, I just think that, we see so many patients that have now devices that are on anticoagulants or antiarrhythmics. We have to know as much about those as our internal medicine colleagues, and have to do then interventions on people with those medicines on board.
No, I'm with you. And I completely agree, as I usually do with you. But anyways, I think that's about all I had to cover, unless you want to throw anything else with. But just again, we can't thank you and the rest of the team enough for putting this stuff together. General surgeons and the rest of the surgical community really needs a place to turn to get this information. And I think you've done a fantastic job, as always. With this.
Thank you. It was an honor. I really appreciated it.
Thank you for joining us for this Surgical Clinics podcast devoted to cardiothoracic surgery. The 4 articles discussed, as well as 8 others, are in the June 2022 issue, Volume 102, Number 3. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, Stitcher, or Amazon Music. Thanks for listening.